Bismillahirrahmanirrahim. Assalamu alaikum dear students. Welcome to your channel The Anatomy Canvas. In today's class of the embryology of the cardiovascular system, we are going to discuss with the clinical correlates of the development of heart. So learning outcome for the today's class are to describe clinical correlates with septum formation in atrium and atrioventricular canal. The incidence is that these diseases are present in 1% of the live-born infants, and this incidence increases to 10 times in the stillborn babies. 12% of the babies having cardiac defects have chromosomal defects as well, and it is basically multifactorial in origin. Different factors like rubella virus, the thalidomide, retinoic acid, alcohol, and maternal diseases like diabetes mellitus also plays a role. Targets for the genetic are the teratogen-induced heart defects are the cells from the areas of forming the areas that is the primary heart field or the secondary heart fields, are the neural crest cells are endocardial cushions. So the cells present in these four locations are basically target cells for these genetic or teratogen-induced heart defects. So first a little bit revision from the previous class, that is about the dorsal mesenchymal protrusion. So in this diagram you can see that this is the developing heart tube, and behind this area is the dorsal mesogastrium, whose dorsal mesocardium, whose central part is breaking down to form the sinus, and here is the foregut, and behind the foregut is the dorsal aorta. Then you can see in this diagram that the septum primum is forming. Here you can see the endocardial cushions are present, and the right and left atria and right and left ventricles. Here you can see this is the dorsal mesocardium, and this dorsal mesocardium is incorporated into the wall of the left atrium, and this dorsal mesocardium is basically responsible for formation of the pulmonary veins. So this was just a revision from your previous knowledge so that you can understand the anomalies related to this dorsal mesenchymal protrusion. First anomaly is total anomalous pulmonary venous return. This is the anomaly which is related with dorsal mesenchymal protrusion, and in this case this DMP is deviated to the right side so that either the pulmonary vein, first look at this diagram. This is the normal heart and this is the anomalous heart. In this you can see right atrium and left atrium, right ventricle and left ventricle, interventricular septum, interatrial septum. This is the pulmonary artery which is exiting from the right ventricle, and the aorta which is exiting from the left ventricle. So here in this diagram you can see these are the pulmonary veins, and their origin is deviated to the right side because of the deviation of dorsal mesenchymal protrusion, and because of this deviation the four pulmonary veins either arises from the right atrium or even into the superior vena cava. So this one is the anomalous connection between the pulmonary vein and the superior vena cava. So the condition is called total anomalous pulmonary venous return, that is supracardiac in origin, and this is because of deviation of the DMP to the right side. Second anomaly is the Holt-Oram syndrome. This is basically because of the gene which is affected is the TBX5 gene, and there is defect in preaxial or radial limb development associated with the atrial septal defects. So in this you can see in the thumb there may be aplasia or hypoplasia, or triphalangeal thumb may be present. Also the middle phalanx can be affected, little phalanx can be affected. There may be synostosis of the carpal bones as well, and the radial bone either complete or partial absence of the radial bone. In addition to this there will be the atrial septal defect. There may also be ventricular septal defects as well. So this Holt-Oram syndrome is one of the type of the heart-hand syndrome, also called the heart-hand syndrome, and it has a genetic origin. The TBX5 gene is involved, and it is an autosomal dominant disorder. Next disorder is the hypertrophic cardiomyopathy. It is again autosomal dominant disorder. The mutant gene involves the beta myosin heavy gene, and the locus of the mutation is 14q11.2 on the 14 chromosome. This is basically affected, and because of the mutation, beta myosin heavy gene is affected and results in disruption in organization of the cardiac muscle. So this hypertrophic cardiomyopathy is one of the reasons for the sudden death in the athletes. Next anomaly is the ventricular inversion. In this ventricular inversion, you can see the morphologically left ventricle is present on the right side, and it is connected to the right atrium to the mitral valve, and morphologically right ventricle is present on the right side and is attached to the left atrium by the tricuspid valve. So in other words, there is the L transposition of the great arteries, and there is this basically reason is when there is laterality sequence is generating, and both right and left sided nets of heart are forming. The defect is over there. The reason is over there that the laterality pathway is basically affected. So condition is called ventricular inversion. That is morphologically left ventricle present on right side, and pulmonary artery is attached to the left ventricle, which is present on right side. Similarly, morphologically right ventricle is present on left side, and the arch of aorta is exiting from the right ventricle. So this was the ventricular inversion. Next is the hypoplastic right heart syndrome. Hypoplastic means there is underdevelopment of the right side of the heart, and is again a very rare defect. In this diagram, you can see this is the healthy heart, the right atrium, the right ventricle, left atrium, and left ventricle. So in this condition, there is underdevelopment of the right side of the heart. Basically, pulmonary artery is also affected. Either there is atresia of the pulmonary artery, or there may be stenosis of the pulmonary artery, underdevelopment of the right ventricle, as well as the right atrium may be small. There may be a ventricular septal defect as well. So this is the hypoplastic right heart syndrome. Another anomaly is the hypoplastic left heart syndrome, and this is again because of underdevelopment on left side of the heart. Here you can see the left ventricle is very small, and aorta is actually either stenotic or atretic, and there is always patent foramen ovale, and left atrium is also smaller in size. So there is the underdevelopment of left side of the heart. The condition is called hypoplastic left heart syndrome. So next defects are the osteum secundum defects. In osteum secundum defects, first look at this diagram. This is the normal septum formation, which I have previously described you in the previous class. In this you can see this brown color area shows the septum primum. This green color shows the septum secundum. Here the endocardial cushions are present, and this opening is the osteum secundum, which is later on will form the oval foramen. So in case of the osteum secundum defects, in this diagram you can see there is the excessive resorption of the septum primum. So septum primum is excessively resorbed, leads to a large defects in the interatrial valve, that is the osteum secundum defects. And in this diagram you can see this is the large foramen ovale. Septum secundum is present, and underdevelopment here over excessive resorption of the septum primum is here. Another anomaly is the cor triloculare biventriculare. In this condition, cor triloculare biventriculare, there is a complete absence of the septum primum and septum secundum. There is common atrium and two ventricles. Cor means from heart, triloculare means having the three chambers, and biventriculare means having the two ventricles. So in this condition, there is complete absence of septum primum and septum secundum, which are forming the interatrial septum, and there is common atrial chamber with the two separate ventricles. So this is the cor triloculare ventriculare. Another condition can be absence of the septum secundum as well. Septum primum is present and there is a defect in the interatrial valve because the septum secundum is not forming. Another condition is the premature closure of the foramen ovale. So this is normal in this foramen ovale is present, and this is the shunt through which the blood enters from the right side of heart to the left side of the heart and then to the parts of the body. So if there is a premature closure, it will affect the baby, and it is a fatal condition and it will lead to the fetal death soon after the delivery. Another clinical correlate is the persistent AV canal and the osteum primum defect. In this you can see the AV canal is common. There is a common AV canal. There is no partitioning between the atrioventricular canal. So this one is the normal, in which you can see separate AV canals, and in this condition you can see there is a persistent AV canal. So common chamber between two atria and two ventricles, and the defect is because of the osteum primum. In this you can also see there is the osteum primum defect which is present. Endocardial cushion is as such present, dividing the atrioventricular canals into two, but because of the defect in the osteum primum there is abnormal opening over here. So these are the osteum primum defects. Next condition is the tricuspid atresia. In tricuspid atresia, so look at this diagram. This one is the normal. In this you can see the right atrium and ventricle, left atrium and ventricular, normal ventricular septum, normal interatrial septum. This is the pulmonary artery and this is the aorta. So in this case, when there is the abnormality in the tricuspid atresia, there is the tricuspid valve is stenotic and closed, which will lead to the large ventricular septal defect as well as underdevelopment of the right ventricle. And there is also the hypertrophy of the left ventricle, and in addition to this there will be the patent foramen ovale. So these are the symptoms which are related to tricuspid atresia. That is underdevelopment of right ventricular, hypertrophy of left ventricular, patent foramen ovale, and a large ventricular septal defect. So another anomaly is the Epstein anomaly. Look at this diagram first. This is the normal heart. This is the right side of the heart, left side of the heart, right atria and ventricle connected to the tricuspid valve, and this is the left atrium and left ventricle connected to the mitral valve. So in Epstein anomaly, the tricuspid valve is basically displaced towards the apex of the ventricle, and as a result of this there will be enlarged right atrium and a smaller size of the right ventricle. So condition is called the Epstein anomaly because of displacement of the tricuspid valve towards the apex of the right ventricle. So here I complete my today's class. The references are the Langman's Medical Embryology and the Gray's Anatomy. Thank you very much dear students for your attention for the today's class, and inshallah we meet in the next class. Till then, Allah Hafiz.